we're going to do an activity in a little bit, but I want to set that activity a little bit up for you all and explain what we're going to be doing. Throughout our 3 days, we have been talking a lot about what is missing, and that has been a theme that I have heard come up from you all throughout this time, is like, we know we have gaps. We know we need things. In our current continuum, while there is not where we need it to be and where we want it to be. And this is just a slide to really show you all at CareOregon how we think about the continuum of care and the buckets that we kind of think about when we're thinking about youth substance use services. And that kind of branches from that start of consultation, so thinking whether that's doc to doc about meds or whether that's therapist to therapist or therapist to doc, like we know we need consultation supports and services to build those skills. We know we need primary-based medication for use disorders. We know that we need school-based health centers, peer services, outpatient, and of course our inpatient and residential, and we would include withdrawal management in those types of services. So this is just a visual kind of how we think about it in the larger buckets. Also, we have spent some time thinking about what is missing and where we want to focus in the next 3 to 5 years. And I say that both to orient you to like, we are talking long-term, and for that reference point of some of these things take a long time to build and come to fruition. And we just need to think about that and remember that, but that's not a reason to focus on it. So at CareOregon, the identified areas that we're really thinking about are these 4. We really want to see continued build out of access to buprenorphine across systems, whether that's primary care, whether that's in the schools, whether that's in custody, whether that is wherever we want that access to happen and we want it to be readily available. And we also don't want to see people turned away if they are engaged with medications, right? So we want that continuity of care that we have in our adult system. We are really focused on continuing our overdose prevention access efforts. So this isn't just, for us, this isn't just, you have a use disorder, here's access to overdose prevention. It's everyone has access to overdose prevention so that we can help folks in the community as an overdose happens. And for youth, we've talked a lot about this, but also moving beyond that piece of, this isn't just about folks who meet criteria for a use disorder, right? This is about folks who use at any given time for a variety of different reasons and can have risk for overdose. We know in Metro that we need more residential and withdrawal management options for youth. I don't know that I need to say much more. I think we're probably all in agreement. And then another thing that we have been really impressed by and really want to see grow is our youth peer services and our youth council services. So really allowing peers that that ability to come in and do what they do that no one else can do, really. So this is our 4 areas that we're really focused on, and we're going to use those to guide a conversation and some discussion today because we want to hear from you all about these areas. So in a minute, we are going to be breaking off by table. And each table has actually already been given a stack of materials in the center of your table. So you have been assigned one of these areas. In your groups, we want kind of 2 main volunteers identified, so somebody to be taking notes. We are going to collect your notes because we want to see them and we want to see all the things you guys are coming up with. And then a second person is a reporter. So at the end, we're going to be sharing out just a couple of really high level points that you came up with in your groups. So like I said, each table's been given a focus area. You're going to have 20 minutes to think and discuss and write down. And really what we want to hear from you is, for your area, what do you think is missing right now? What would you love to see? Big picture, paint your dreams, throw it all out there. Okay, so we want to think like pie in the sky for whatever you have. What would you love to see us have in the metro region available to folks? I do want to call out that some of you may have a focus area that you know absolutely nothing about. That's great. We're okay with that. We, in fact, want that to happen. We really want to think about breaking down silos in these conversations and kind of really pushing our level of expertise. And also, you probably might have somebody at your table you just don't know yet who has that knowledge. So we'd love for you to build some friendships and relationships while you're having these discussions. Okay, so without further ado, we are going to go ahead and get started with the discussion portion. We'll reconvene in about 20 minutes. Y'all, I'm going to be honest with you. We were not sure how this was going to go. And that was the most discussion I think I've ever heard at any discussion breakout. So I'm super excited to hear about what you all came up with. So how we're going to do share outs. You should have your speaker or your sharing out person identified. We have a mic stand up here so folks can come up and line up as they're ready. No? If you do not want to do that, we can bring the mic around to you if you prefer that. So we're just going to go ahead and we'll go table by table. You can please let us know which topic area you had, and then your 2 points, your couple points that really stuck out from your conversation. And then either if you want to drop your notes just on the stage if you choose to come up, or you want to just hand them over to your CareOregon mic person if you choose to stay seated. So I see one volunteer ready to go.
Hi, my name is Daryl Ann, and our topic was primary care-based MOU prescribers. And we had a lot of discussion. As you can see, we have lots of suggestions, but the most common one is that we felt like pediatricians should be trained. If they had more training in prescribing, then there would be more access for our youth. Right now, that is a problem because there just aren't very many psychiatrists, there aren't very many substance use prescribers, and that's not an area that they often feel comfortable in prescribing. So that was primary, as well as like, okay, so now if they're prescribing, who's sort of supporting, who's doing the therapy, who's doing the treatment part of that? And so having a list of clinics who have prescribers and having a list of, which we do have a pretty good list of treatment providers now, so that's helpful. We also talked about an emergency department doesn't have a handoff. Like when we are speaking from a pediatric clinic, we have a youth who shows up in the emergency department with substance use overdose. There really isn't any sort of workflow for follow-up. And so that resource really isn't happening from the emergency department.
Great. Thank you so much. I see a line forming. If you want to, go for it. Yeah, come on up. Like the new Bob Barker.
I've never actually spoken into a microphone before. This is like really exciting for me. Okay, and so our topic was peer services. And a couple things that we thought is that literally anybody in any setting who identifies as somebody struggling with mental health or substance abuse should have the resources to be able to be immediately connected with a peer. And we wanted to take that even one step further based on the age demographic. Like, look at them. They're all on their phones right now. There should be an app. There should be an app to connect you to a peer. a game. Make it fun. Give it noises, colors. They'll like it. We also brought up the point that things that we see in the media, these celebrities, what they're doing, these kids want to follow that. And so we're talking about make recovery trendy, make recovery dope. Because I know that, like, for me personally, I had to go out of my way to ask about fentanyl because I was so uneducated. And I'm somebody who is in recovery for substance abuse myself. It's just that it hit the scene after I left. And so I had to do some serious digging and go very out of my way to even become educated about fentanyl. I want to see Kim Kardashian or somebody talking about how it kills. As far as the public school system goes, we want to see tools for mentors and peers to be inside the schools. Make the peers more accessible. And we're saying that shouldn't just be for people that are already at that point where, you know, they're needing to be in intensive outpatient, residential. Like, literally every single person should have access to a peer regardless of the level of care. Peers in schools, and and then that also, once they learn how to kind of network with more peer support, then that will give them the tools to go and help other kids. Because who better than, you know, their friends? We also want to see less abstinence-based education and more harm reduction focused around youth. As well as trauma-informed care. We also want more dual diagnosis care, because I know that we all know that this addiction, these substance abuse issues, they all stem from somewhere. It is all the same monkey. We want it all looked at. And we also want these youth to have self-referral opportunities. And then, okay, so I'm a peer support specialist, and we literally always make the joke, because I work with youth, we make the joke, we're like, oh, no, I'm not talking to your parents. If they want peer support, they can get their own peer support. That shouldn't be a joke. There should be peer support for parents. There should be somebody to support parents of youth who are struggling, and so that they better know how to actively support their children. And we think that the peers should have more access in collaborating with case managers for wrap-around care. And then I also want to, this one I'm going to, I know I've already been speaking like very loudly, but this one I'm going to like yell to the walls. I am so passionate about the fact that we do not have enough beds anywhere. Nowhere. I currently have a peer, and he is on a 2-year wait list for an independent living program. I want to see more beds everywhere, whether it be detox, whether it be inpatient. Please help these kids get where they need to be so that they can get help. I don't want people waiting it out before they can get help. And as far as that help goes, also insurance should cover peers. Thank you, mic drop.
My name is Anya. I'm from Clackamas County. And we had a little wide group of people from the schools, middle school, high school, specialty substance use, and we spent a little while kind of figuring out what peer services even looks like in all of our different settings, because we had peer services also. And we started by talking about how peer services should really run the gamut for youth, right? From prevention to intervention in outpatient and residential programming. We talked about how we would like money. We just want money, lots and lots of money to pay for all this stuff. But having programs money to pay for programs in the schools to identify leaders, right? All the way from like the middle schoolers to working in like prevention programs to help meet them, like get them where they are, right? Like if they're in school, let's put some training programs and some opportunities for them to learn how, like to have the skills to talk to their friends when their friends say, hey, I'm struggling in this kind of way. Even if that like help is just let me help you connect you to someone who I think could help you. Teaching them how to do that in the schools. We talked about how we want peer support, also want insurance to pay for peer support because we all know that it is a super helpful intervention, and peer services needs to be like a career that people can live on, right? Like we need to pay our peer services specialists money so they can do their job. I know that I have worked in a lot of programs where it's been a requirement that I have had to have my own transportation to transport clients in, and especially if we're talking about having youth support peer services, like we need to help them have transportation to be able to get to clients. That's a big barrier for getting people hired. I have a client who is a youth peer mentor right now, and they cannot get a job because they don't have their own transportation, despite having the training to do that. We also talked about having more education about what peer services does and where to get that training and how to connect our clients. You know, we have people in our table at primary care, from insurance in schools, and that, even for me, like it's hard to try to figure out how to get my teenage clients connected to a peer services in a specialty mental health and SUD program, because there's not a lot out there, and again, like transportation is an issue. So having the structure to have more education about what that actually looks like, having the structure to train our youth into being peer mentors, and then also having the structure to especially for having younger people, right, get started in this career, they need some mentoring themselves in their career to be able to grow it into the profession and provide the services that they want to provide. And we talked about also having kind of like a Lines for Life, like our similar program where, you know, if we can't, I love the idea of the app, right? But like, do we have somewhere we can call and people can just get peer support over the phone or text specifically for SUD? Okay, I'm done. Bye. Thanks.
Hi, I'm Michelle Horan. I'm a youth drug and alcohol counselor at Northwest Family Services. I will say we do have peer support services in Clackamas County and East Multnomah County in the high schools and middle schools, so reach out. We had at this table over here school-based health centers. And we focused on, you know, pie in the sky, what's missing, based on the knowledge at our table of what we know about school-based health centers. And one of the things that we think would be great is more of them. You know, middle schools, elementary schools, what would it look like if we had more than 9 or 12 or however many we have. And then when we do have them, what does that space look like? Is it, is it intentional? Is the creation of the space intentional for, allowing a youth to come in and feel comfortable there? Are there, private counseling rooms, engagement rooms? Like, I'm not saying that's not happening, but just making sure that more of that is happening. Continuing what's working, right? Youth Connection, making sure there's bilingual counselors and people that work in the office so that all youth can be served. More counselors. I work in a school where the wait list for mental health services starts in like November. And by November, I can't refer anyone there because they're full. Reducing stigma to accessing school-based health centers. What is it? One of the people at our table talked about health classes come to their school-based health center and learn what it's about and learn what you can get, have done there. And so continuing to do those things, but also maybe other ways to reduce stigma of going there. Terrence talked about a basket of, if you don't want to say why you're coming, you can go through this basket and say it says birth control, or it says STD testing. You don't have to say it out loud because you don't know who's there. I thought that was fantastic. And then extended appointments, nighttime appointments, weekends. I know that means people have to work more, so I don't want people to work more, but maybe more people, so we can, we have that captive audience at school, which is great. I love that I work in a school for drug and alcohol counseling because hopefully the students are there, so I get to see them. But I think if we had more options for students seeing someone perhaps outside of school hours, that would be great. Thank you.
Hello, I'm Kat Cruz. I work at Clackamas Health Center's primary care. Thanks. We do MOUD and then other medications for addiction within primary care settings. And we're going to start doing 16 and up any day now. Really, as soon as we get a referral that sticks. All right, so we had specialty outpatient youth SUD providers. So what's missing? Providers. So it's really hard to find specialty outpatient for youth SUD. The folks who are around, there's huge wait lists a lot of the times, and a lot of the folks who are providing don't allow folks who are on medication. So we also want to increase providers who do embrace medications for addiction, also not perpetuating stigma. Again, resources are limited. Hard to enter care when 100% abstinence is overwhelmingly the option. So how do the youth get to a place where they can be 100% abstinent to get that care? So obviously increasing detox options. Harm reduction, someone wrote, harm reduction is for adults only. Why? So yeah, increasing harm reduction options for youth. And more transparency about what's available. So I think we were Googling what's available. I know some people from being in this work for so long, but I overwhelmingly work with adults. So I'm just I don't know who's around right now. And so the second part, what do we want to see? So full continuum of care. We want more than just what we have. We can't just add prescribers for mental health and behavioral health and if there's no options for withdrawal management, residential, et cetera. I wrote, again, more transparency, what's available, what do you offer, what's your hard no, where are you flexible? Better linkages. So again, this is I know a bunch of people in adult places, but I don't know a bunch of people in youth, and so that's part of the reason we're here, right, is to make these connections. But I was thinking about, we are super close with our corrections, adult corrections. I don't know anyone in youth corrections in Clackamas County. I could find out. But yeah, so more of that. I know one of our beautiful Gladstone human, she works really well with our foster system, getting that going. Getting better linkages between school-based health centers and outpatient, clearing the pathways, and then payers paying. So repeating peers should be reimbursable, making sure we're able to get things paid for that we weren't able to get paid for before. Yeah, thanks.
Hi guys, I'm Stacy Mahoney. I'm a school therapist at Harmony Academy, which is a recovery high school in Lake Oswego. Our group in the back talked also about the primary care setting, so along that first group. And I think some of the themes were just about the absence in those care coordination meetings that other settings might be having of primary care representation, specifically prescribers. And so what is that about? Is that about time allotted? Is that about reimbursement? And so thinking about why those barriers exist and make sure they're sitting at the table. So when we're in, for example, wraparound meetings, that voice and consideration is heard. I think the first group also said this, but just around what the education and training in the primary care setting is looking like. And we specifically highlighted a couple areas that we thought would be helpful. One, as was brought up in a conversation during the earlier training, like the being a mandated reporter and what that looks like, and knowing that that takes time. But when the first person, if it's a physician, is hearing the concern for report, like having them make it, and rather than passing that along to a social worker or other behavioral health provider. And again, what's that about? Is it about the time constraint? Is it around the burden of potentially affecting a relationship? But figuring that out and providing that education. More harm reduction in those environments, more peer support in those environments, coordinating around, again, is this education, or what's the barriers to getting releases to coordinate and having more open coordination? And then considering having the primary care setting offer 0.5 level of care services, and along that same line, also who's in those settings that can be completing ASAM assessments and looking at our community to just use that level of care guideline and assessments to get folks connected to the services more consistently. And then just in general, what are the barriers, and are we, timing and billing seem to be some of the key ones, but are we missing something, and making sure we're talking about the barriers. And then making sure that language and cultural considerations are being provided and offered. And in the, I think this came up somewhere else, but when folks present to the ED or urgent care, what screenings are happening out of that setting that involve substance use, and how are they getting looped back into the medical home bases?
Hi, I'm Brenda Brischetto. I'm a family physician. I work with the residency program at Providence, Milwaukee, and so we're in Clackamas County, but we also have a clinic that they're based out of that's in Multnomah County at 82nd and Holgate. And just, I'm hearing about, the need to train people. I will say that we are training family medicine doctors, and some of them are very enthusiastic about continuing to do addiction medicine. We have a few graduating who are going to go into fellowships for addiction medicine, and most of our residents end up saying that that's a focus of interest for them for the future. So just a little bit of optimism there. Our group was actually talking. We had a number of providers and also people who are in LifeWorks and other places represented at our table. We were specifically talking about inpatient residential. I think a lot of it was about just barriers to accessing those resources, ones that are close enough to family and support systems and they aren't so far away, that difficulty in actually just the wait times, 4 to 6 weeks or more to actually just get a bed, transitioning, actually the length of stay being adequate so that they're more successful, and transitioning into outpatient, having more of a step-down plan, really connecting people instead of just giving a phone number as they leave. So wanting that to be better access and more set up for success. Also, we really talked about, and I've heard other people echo, the dual diagnosis being an issue. When there's eating disorder, when there's other psychiatric diagnoses, that's a real barrier to people being able to even get in and be medically cleared in order to get a bed. And then some, just the different kinds of resources that are out there, that a lot of them have to have detoxed before they can access those particular treatment options, and having enough detox centers for this age group. Insurance being another barrier. OHP seems to have so much better access than a lot of private insurers. And how can we help youth qualify for OHP? There was some discussion, and this isn't my field, so I don't know as much about it, like the household of one. How can we look at this individual as someone who might be able to qualify for insurance, for Medicaid? And then also talking about, we would really love to see a little bit better support around getting school credit and being able to study so that they don't lose a bunch of time with their education. and how do we support the families? How do we get them the support for their social determinants of health that have gotten them to, needing housing, transportation, utilities? How can we help them access these things, and educate the families about how to support their youth? So those were our ideas. Thanks.
Wow, so much was covered. We did narrow ours down to just 2 things to share out, so I'm just going to wrap it up. But we talked about consultation and thinking more along the lines of wanting something that's like a community consultation that anybody could call and get support on SUD-specific things, or like resources or how to navigate a SUD-specific issue for youth. And so we talked about we need a 211 resource style SUD consult. And then the other part of that is like funding for that and funding to advertise that. So anybody in the community could use it. That's all.
Thank you all so much. This has been super helpful, and I'm so grateful to hear all of your perspectives and your input, so thank you. A little bit about where this goes now. So we are going to be taking all of that. Lauren's actually been in the back taking some notes for us. And we are going to take all of your handwritten notes and synthesize them into one document, which will then be going back to our Youth Substance Disorder Task Force, where they will get to reflect on the information that you've provided in the feedback, and will help set our strategy for the coming years and where we want to focus and what things we need to build out. So just know that it's going somewhere. People in this room are going to be looking at it still. So appreciate it. And, that was just really successful exercise. So thank you guys very much for that.